You missed me, haven't you? Well, I'm back and ready for another Persiflager's Puscast. Review the infectious disease literature with snarky commentary for the first 2 weeks of August 2009. Remember, you can skip this intro and move on to the next chapter. This is on iTunes, and as always, if you love me, please write me a rave review on iTunes and feed my endlessly ravenous ego. This is brought to you by Pusware LLC, the publisher of the Persiflager's Annotated Compendium of Infectious Disease Facts, Dogma, and Opinion, your uber hyperlinked and somewhat peculiar electronic guide to infectious diseases at pusware.com. This is Type 1 CME accredited. After you've listened to my babbling, take the online quiz and get a free half an hour of CME, thanks as always to Legacy Health System. Because it's CME accredited, I must mention my conflicts of interest. I ain't got none. Also, remember my Quackcast, or occasional review of supplements, complementary, and alternative medicine. I write twice a month for the Science-Based Medicine blog, and of course, 3-4 times a week at Rubor, Dolor, Kalor, 2 more, available at Medscape. I have a multimedia empire so that you can always get your fix of Mark Crislip. Because remember, the world needs more Mark Crislip. And now, on to the literature. I'm running a little behind this month because I spent the last several days trying to get on the death panels that Sarah Palin has promised us. I think that would be a fun way to pass my time determining whether or not old people have the right to live or not. I love healthcare reform. So we're going to start with influenza. How good is the rapid test? Well, the CDC tested 3 commercial kits to see how good they were for determining whether or not someone had flu. They found that it was pretty good for seasonal flu, around 80%. But for the H1N1, it was only around 40-ish% to as high as 60%. And that it was most valuable when there were high titers of flu in the specimens. So the important thing about the rapid flu test is that it's only helpful if it's positive. A positive test tells you they have the disease. A negative test doesn't tell you they don't have the disease. So let's just say that there's a febrile coughing patient in your ER or clinic. Don't be a dumbass and take off your respiratory protection on the basis of a rapid influenza test. That's presuming, of course, that you're not a dumbass already and have not put on a mask when you walk in to see the febrile coughing patient. Remember that the cough is a very effective way of spreading infection. The reason you have the patient turn their head and cough when you're testing for hernia is you don't want them coughing on you. Turning the head doesn't help bring the hernia out. The only thing that's probably more efficient for spreading disease is sex, and I've said many times, if someone coughs on you while having sex, you're bound to get infected. And the New England Journal article this month gives a nice example of how infectious influenza can be. They looked at the outbreak in Mexico, and they looked, amongst other things, at what happened to healthcare workers. 22 of 190 healthcare workers who cared for the first 3 patients in the emergency room or the ICU came down with influenza. 19 of those were within 2 meters of the patient, however far a meter is. I think that's like 6 feet or some rational distance like that, or had direct contact. So 22 of 190 people who took care of the first 3 came down with influenza. That's a pretty good transmission rate for care in the hospital. Turning our attention from influenza to HIV, this study was in the Journal of Acquired Immunodeficiency Syndrome and looked at the risk in Spain of developing meningitis if you had HIV disease. This was bacterial meningitis. And the rates in HIV patients was 62 per 100,000 versus 3.2 per 100,000 in them what didn't have HIV disease. They usually had CD4 counts below 200, and they usually had, not unsurprisingly, Streptococcus pneumoniae as the cause of their bacterial meningitis. But that rate is 19 times higher in the HIV population than the non-HIV population. There also more likely to have neurologic complications, a higher than average case fatality rate, and a greater incidence of neurologic sequelae. So it's bad to have HIV, and they can add bacterial meningitis to the diseases that those patients are at increased risk for. Or perhaps I should have said for which these patients are at risk. Efavirenz, known by its brand name Sostiva, gives people all sorts of neuropsychiatric reactions. They have weird dreams, vivid dreams. They get dizzy. They get a feeling of drunkenness and dizziness. If this drug had been invented in the 1960s, it would probably be illegal and sold on the streets in Haight-Ashbury. The problem is the neuropsychiatric complications, the goofiness, or as they call them in this study, efavirenz-related neuropsychiatric adverse events, or NAPIAs, are common and are limiting in the medication. So they figured rather than give people maximum dose all at once, which is 600 milligrams a day, they would randomize them to receive either the standard dose or increase it over 3 weeks. They found that by the stepwise escalation of efavirenz over 2 weeks, they reduced both the incidence and the intensity of feeling goofy, or as they call them, efavirenz-related neuropsychiatric adverse events. The dosing schedule is 200 milligrams a day for the first week, 400 milligrams a day for the second week, and 600 milligrams a day thereafter. And not to be confused with a few martinis. So this woman from Cameroon moves to Paris, and she gets tested and finds a retrovirus in her blood that looks unlike any other HIV anyone had seen before. So they go to work, and they figure out that she's actually infected with a simian virus that's found in gorillas. Now, she had never been around a gorilla, but she'd had several sex partners after her husband had died, and perhaps that's where she acquired the infection from. But not only is there HIV in chimpanzees, which are the likely source of HIV-1, but there is an HIV also in gorillas that has the potential to infect human beings. This patient is not, as of the report, ill with the gorilla HIV, although she now has an urge to pound her chest when angry. Let's see if I can get this right, because this is a complicated article from Emerging Infectious Diseases. Hepatitis B has 8 different genotypes, A through H, due to a viral polymerase that can't do proofreading. It's kind of like my son for his English classes. As a result, there are different genotypes of hepatitis B found throughout the world. Now, they've looked at the hepatitis strains in Haiti, which has a population that is greater than 90% descended from slaves, and found a high prevalence of genotype A1, which is primarily found in Eastern Africa. They do not have much in the way of hepatitis E or A3 in Haiti, both of which are more likely to be found in Western Africa. By looking at the variation in strains of hepatitis, they have determined that the Haitian strains probably came over from East Africa. Currently in West Africa, the type of hepatitis that's found, which is E and A3, and are rare in Haiti, probably occurred in that population after the slave trade ended. So they can see how the hepatitis has spread from Africa to Haiti, and how then new strains became dominant in other parts of Africa by looking at the genotypes of this virus. This stuff makes my head hurt, but on the other hand, it's really cool. Even more interestingly, they figure that most of the hepatitis in Haiti came from a part of Africa known as the Bight of Benin, B-I-G-H-T. It's not a food festival in Africa, but a bay near Cameroon and Nigeria, which was a central point for the slave trade. So everybody came into this area, got hepatitis B, and then were shipped to Haiti. To give you an idea what a nasty place this used to be, according to the Wikipedia, there's an old rhyme that says, "Beware, beware the Bight of Benin, few come out though many go in." sort of an abandon all hope ye who enter for the West African coastline. Group A strep, of course, can be a particularly nasty infection causing necrotizing fasciitis and toxic shock syndrome. There have been cases of the organism being spread in hospitals, and there have been cases of patients who've received it from their healthcare worker. Now there's the case report of a patient who gave their Group A strep to a respiratory therapist, probably not as a gift, and the respiratory therapist came down with toxic shock syndrome. The take-home message of this case is that infection control policies and procedures are there for a purpose. The patients who have Group A strep should be both in droplet and contact isolation for 48 hours on appropriate antibiotics before removing them from isolation. Not only can Group A strep be spread in the hospital from healthcare worker to patient, but it can be spread from the patient to you. My rule of thumb with all these particular infections, if you walk out of the patient's room, you should feel comfortable licking any part of your body that was in that room, because you're going to eat a sandwich or pick your nose or do something else to transfer it from your hands to the rest of you. And if you're not comfortable licking any part of your body, maybe you should have used proper infection control policies with that patient. There was an outbreak in Uganda of bubonic plague in 2006, and the MMWR of 2009 discusses the issue. No surprise that there's occasional outbreaks of plague and people die of plague, especially in areas of limited resources. There's one quote here that I just find particularly interesting, and I'll spare you my faux Queen Victoria accent while I quote, "Also highlighted by this investigation is the effect of local beliefs on care-seeking behavior," which I suppose they mean is seeing a doctor. "Anthropologic studies have indicated that tribes living in the Arua district hold diverse beliefs about disease causation and the role of supernatural in human illness. Investigators observed that the villagers initially ascribed an outbreak of pneumonic plague to feuding rather than to a disease that can be treated with antibiotics." End quote. I find the parallels with those who are proponents of supplements, complementary, and alternative medicine, i.e. scams, to be quite striking. And it's often that they have supernatural ideas about medicine that have no bearing on our known reality. Whether it be the undereducated beliefs of tribes in Africa or the overeducated magical thinking of chiropractors and homeopaths, to believe in magic is to believe in death. And let's just say, for fun, that you're a wildlife biologist and you come across the corpse of a mountain lion. So you figure, let's see why it died. So you take it to your garage and you do an autopsy, and you don't use any personal protective equipment. 3 days later, you get fever and hemoptysis. 6 days later, you're dead. Both the mountain lion and the biologist died of bubonic plague. Don't be messing around with the corpses of dead animals without using personal protective equipment. I remember years ago reading an article in the New Yorker about a national park warden, or maybe it was another biologist of some sort, but this person consumed a diet primarily of roadkill. I wouldn't do that. Except maybe cat. Being run over by a car is a tenderizer. By the way, the presumptive source of the Yersinia was aerosolization of dead mountain lion parts during the necropsy. There have been other cases of this sort of transmission during an autopsy from one animal to another in humans, the best being a bunch of people who came down with tuberculosis when they didn't wear masks at an autopsy of someone who died of miliary TB. When you cut into things, you aerosolize them, and you may suck those bacteria into you. Corynebacterium diphtheriae causes corynebacteriumitis. No, not really. It causes diphtheria. but it's not the only organism that can cause a diphtheria-like illness, and Corynebacterium ulcerans can make a toxin that causes an infection that looks just like diphtheria. It primarily has been associated with contact with dairy cattle, but there have also been publications to suggest that pet dogs and pet cats can be carriers of Corynebacterium ulcerans. The cats have often a bilateral nasal discharge, which in and of itself must be disgusting. However, there's now a case report of somebody who had a Corynebacterium ulcerans diphtheria-like disease who probably got it from a pig. The patient had a diphtheria-like syndrome that turned out to be the Corynebacterium ulcerans, so they did an outbreak investigation of their pig farm. They did pharyngeal swabs of the family, all negative. The family dog, all negative. There's only one. And this must have been fun, pharyngeal swabs of 19 pigs. Thank God it's not a rectal carriage infection. And they found one of the 19 pigs had an asymptomatic infection with the toxigenic strain of Corynebacterium ulcerans that infected the index patient. So, be wary of dairy cattle, dogs, cats, and now pigs if you got a case of diphtheria that's not due to Corynebacterium diphtheriae, but Corynebacterium ulcerans. Of course, I'm doing my best to keep my risks at a minimum for both swine flu and Corynebacterium ulcerans by maximizing my bacon consumption. So, what do you do when you have an MRSA that's failing vancomycin? As it says in the article I'm about to quote, most infectious disease doctors would either add rifampin or add an aminoglycoside to the therapy. Is that the most effective therapy? Now, this study looked at 35 patients who had persisting, greater than 72 hours, of positive blood cultures from MRSA. And they were randomized to either get aminoglycosides or rifampin, or instead they got linezolid plus a carbapenem. And it turns out that them what got the aminoglycosides or the rifampin went nowhere fast, while them what got the linezolid plus the carbapenem had an 88% response rate to the linezolid-based therapy. 88% versus 0. I wonder which one you're going to go with. As an aside, carbapenems do have the ability to interact with the penicillin binding proteins of MRSA, and while not as good as might otherwise be expected for susceptible organisms, you can get efficacy, and there are other in vitro studies to suggest that the combination of linezolid and a carbapenem is efficacious. And in my N of 1, I cured my one patient whom I couldn't give vancomycin to, who had an MRSA infection. I treated him with linezolid and ertapenem, and I cured his endocarditis. 3 interesting reports in reference to Legionnaire's disease. The first was a pseudo-outbreak of Legionnaire's disease in Arizona when the ice machine became contaminated with Legionnaires, and as a result, they started seeing Legionella in the BAL specimens of patients who are getting ice water to control bleeding. None of the patients developed Legionnaire's disease and did not have the clinical findings of Legionnaire's disease, but it was a pseudo-outbreak because people let their ice machines become non-sterile and grow Legionella. There are also 2 interesting case reports with Legionella. The first was out of Spain, where they had a community-wide outbreak of Legionella with 55 cases. They found that it was due to cooling towers at a power plant that had received inadequate maintenance. This is the second cooling tower-associated Legionella outbreak that I have read about. There was another one in France not too long ago. And lastly, they went around in Japan and looked for the presence of Legionella in puddles that form on roads after rain. They postulate that perhaps splashed water could be a source of Legionella. They found that Legionella was, quote, abundant in these puddles, especially during warm weather. It was shown in clinical infectious diseases several years ago that Legionella increases shortly after thunder showers in warm, humid areas. That study was done in Philadelphia. And here in the Great Pacific Northwest, whenever we have thunder showers, I look for cases of Legionella. The The last case I picked up was a guy who spent a lot of time slopping about in the puddles in his backyard after the thunder showers. I never did look to see if there was Legionella in his puddle water. Take-home message: don't inhale ice water, don't inhale cooling tower steam, and don't inhale puddles. Endocarditis is a bad disease. Man, I'm a good clinician, huh? This study, published in the journal Circulation, looked at the incidence of embolic events to the brain in patients with endocarditis. They either looked at acute brain embolization or subacute brain embolization. What they did was MRIs of 56 patients with left-sided endocarditis, and they found that a significant number of patients had signs of a bacterial embolization, 48%, and 80% of patients had signs on MRI of subclinical bacterial embolization. Then what had emboli had a 10% higher mortality rate. I'm not surprised at this finding. I always assume if you can find evidence of embolization elsewhere, that the patients have probably had some to the brain, and this confirms that particular clinical bias of mine. The rule in medicine is to never let the sun set on a pleural effusion. Probably not true if you practice in Barrow, Alaska, but true in the rest of the world. And it may be true of brain abscesses as well. This study was retrospective. It looked at 62 patients who had loculated infected cerebral collections over a 4-year period. And they found that patients who had a delay in their surgery had a tendency, though not statistically significant, for both a worser outcome and a more prolonged stay in the hospital. And those who had longer duration of antibiotics because of the delay also had worser outcomes. So if you have a brain abscess, the sooner you drain it, probably the better. There is a tendency of some surgeons to be somewhat reticent in getting pus drained, saying, let's start the antibiotics and see how they do. I sometimes wonder if these surgeons have a part-time job in a mortuary. There has been a smattering of articles of late suggesting that cultures need to be held for longer periods of time to find more fastidious organisms, especially if you're treating infections associated with prosthetic material. For example, joints should probably be held for 10 days to 14 days, as you're more likely to recover things such as P. acnes and coag-negative staph. Similar study has now been done with shunt infections, where they had an increased yield of their cultures of the CSF if they were held up to 10 days. The organism, again, most likely to be voted slowest to grow was Propionibacterium species. P. acnes is probably a bigger pathogen than we're aware of because we don't hold the cultures long enough, nor do we look for it. It's been associated with central line infections, with prosthetic joint infections, and now this article with shunt infections, where it's long been known to be a common cause. But again, you'll miss it if you don't hold the cultures for at least 10 days. There have been a smattering of studies out of Asia, primarily Hong Kong, if memory serves. Maybe it was Singapore, who cares? To demonstrate that patients who are admitted to the hospital with community-acquired pneumonia who get treated with quinolones but actually have tuberculosis have a delay in the diagnosis of tuberculosis because of the efficacy of quinolones in the treatment of TB. These studies did not show any resistance of tuberculosis to quinolone antibiotic. I hate saying fluoroquinolone, it just takes too long. However, this study shows that patients who were on prior quinolones were more likely to have tuberculosis that was resistant to quinolones. The key difference between this study and prior studies is that in the current one, it was distant exposure to TB that led to resistant strains. What's distant? 60 days. Now, resistance is rare. Out of 717 culture-confirmed tuberculosis patients, only 16, 2.5%, had TB isolates that were resistant to quinolones, and about half of these patients did have outpatient quinolone exposure. As I said, the longer ago their quinolone exposure, the the more likely they were to have had a resistant tuberculosis. So not only do quinolone usage decrease the rapidity with which we make the diagnosis of tuberculosis, it may affect the susceptibility of that agent to the quinolones. One of the things we don't do quickly enough in the hospital is often switch people from IV to oral therapy. And this can often be done safely and quickly in patients who meet certain criteria. This study in England had this nice checklist, and you can find the reference online, where they rapidly switched people to oral therapy if they met clinical criteria and had no change in the patient's outcomes. The inclusion criteria were antibiotics for greater than 24 hours IV, afebrile greater than 24 hours, clinically better, able to take oral fluids, and able to take oral medications. Big duh on those two as well. They excluded all the smart thing: cancer, abscesses, osteo, septic arthritis, meningitis, staph bacteremia, endocarditis, and endovascular infection. But if patients had simple, uncomplicated infections that responded rapidly to IV therapy, they switched them to pills, and the patients did just fine. As we're at the 26-minute point, it's going to be hodgepodge time. All those things that I just are more or less one-liners and don't need long-term discussion. First was an article in CID that looked at ciprofloxacin dosage and the emergence of resistance. Usually the motto is what doesn't kill you makes you stronger, but unfortunately no matter what dosing regimen they used, they still got ciprofloxacin resistant in the stool. So that optimizing the dosing regimen did not decrease the emergence of resistance in the human commensal bacteria when using quinolone antibiotics. Bummer. There was an herbal supplement that had artemisinin in it, an anti-malarial drug, and people who took it got hepatitis. Don't take natural herbal supplements. You have no idea what the hell is in them. 3 things that are associated with infectious disease spread in the hospital. 1, X-ray machines. The portable X-ray machines can spread bacteria in your ICU. Another study looked at toilet seats were a source of MRSA in about 3.3% of hospital toilets, and by using wipes on the toilet as well as your butt led to a 50-fold reduction in the bacterial counts of MRSA in the toilet seats. Your watch band also contains bacteria, but almost predominantly normal skin bacteria. In this study that looked at the wristwatches of 100 healthcare workers in a community hospital, only one had a pathogen, and that was Staph aureus. Intimaeba histolytica has long been known as a sexually transmitted disease, primarily male to male, but they've now had several cases of Intimaeba histolytica being spread by female to male and heterosexually, and the big risk was oral anal sex. Maybe Listerine would help that. For those of you that live in the great Pacific Northwest, be aware of the fact that Cryptococcus neoformans continues to come south from British Columbia, and the incidence of this disease is increasing in both Washington State. You can tell someone is actually not from the Northwest because they call it Washington State. Around here it's Washington. But Washington State is having more cases, as is Oregon, from the strain from Vancouver Island. Yet another failure of our border patrol. Don't forget that normal people can have cryptococcal pneumonia, and the most common finding on imaging is multiple, smoothly marginated nodules with an upper lobe predominance. I've had 2 patients get pneumonectomies for a presumptive lung cancer who turned out to have cryptococcus in their lungs, and they were not very happy to be told they had a treatable fungus rather than a fatal cancer. You'd think they'd be happy they weren't going to die of cancer, but you'd be surprised how poorly patients don't like having their lungs taken out for treatable infectious diseases. Remember that smoking is a risk factor for the development of tuberculosis. In China, as in other places, being a smoker is associated with a 10% higher chance of developing tuberculosis than when compared to non-smoking controls. Pneumococcal bacteremia in adult cirrhotic patients is more commonly associated with SBP than pneumonia. according to an article in the Diagnostic Microbiology and Infectious Diseases. I got asked this question just this week. But if you have ascites and you get pneumococcus in your blood, you're more likely to get it from SBP than you are from pneumonia. Speaking of strep pneumo, macrolide resistance has increased a wee bit in this country, going from a stable rate of about 30% up to almost 35.5%. So macrolide resistance is slowly creeping up, just like my boxers in the United States. I'm sorry, was that oversharing? Not only can humans get MRSA from their dogs, but there's a case of a dog who got a post-op surgical infection and died, and the MRSA in the dog was traced to their human master. There's increasing numbers of cases of pathogens being spread back and forth from humans to pets, and that includes not only Staph aureus, but group A strep, and even E. coli causing urinary tract infections. Again, part of the reasons I want to keep these pets, out of my hospitals. Not that I've been successful. While male circumcision is important in decreasing the transmission of HIV, it does not decrease the risk of Neisseria, gonorrhea, chlamydia, trachomatis, or trichomonas vaginalis, at least in this study out of Kenya. However, if you take the foreskin after circumcision and plant it in the ground, when it grows to 6 feet tall, you have a Republican congressman. I was unaware of this, but Rickettsia rickettsiae is found in Central America, specifically Costa Rica, Honduras, Nicaragua, and Panama. And I do want to apologize for saying none of those countries with a Hispanic accent, unlike NPR. But there were cases of Rickettsia rickettsiae reported in emerging infectious diseases in people who had traveled to Honduras. So rickettsia are available not only in the American South, what H.L. Mencken referred to as the hookworm belt, but also in Central America. Blacks do worse with HIV disease and have more concomitant substance abuse than Caucasians. And finally, there's a lawsuit over a death in New York City. The first person to die of swine flu there, their widow is planning a $40 million suit because the city did not take adequate control of H1N1 outbreak and did not inform the patient that he was exposed to H1N1. Like anybody can control a flu outbreak. And that's it. Another exciting infectious disease Puscast for the first 2 weeks of August 2008. This has been Mark Crislip babbling away again. This is CME accredited, so go online and take the quiz and get a free half an hour of CME. Thanks as always to Legacy Health System. This Puscast is brought to you as always by Pusware LLC, the publisher of the Persiflager's annotated compendium of infectious disease facts, dogma, and opinion, your uber hyperlinked electronic guide to infectious diseases at pusware.com. Don't forget to write me a glowing review on iTunes and feed my ravenous ego. Don't forget my Quackcast, review of supplements, complementary, and alternative medicine, i.e. scams, also on iTunes. And you can read my blogs on Medscape, where I do the Rubor, Dolor, Calor, Tumor, and science-based medicine. Yes, I have quite an enormous multimedia empire that you can participate in because the world needs more Mark Crislip. Bandwidth ain't free, so feel free to send a few dollars my way. I'm just pretending that I'm using it for broadband. I actually spend it all on gambling in Vegas. That's just a joke, of course. My wife is listening to this. This is copyright 2009 with the Creative Commons license. The music is by my eldest son when he was 12 years old, improvising on the guitar. And as always, thank you for this most interesting consultation, allowing me to participate in the care of this most difficult and challenging case. I will continue to follow along with you. Thank you. In dictation, goodbye.